Okay, I think we should make a start. So we'll just continue from where we stopped. Some of you have had a refreshing break. It's a lot that we've had to do so far. We still have a lot to do. So we should be finishing this class in about an hour. So it's about 11. And then we're having an afternoon session. So the afternoon session on your timetable says a drill. It will not be a drill, it will be a continuation of the class. You'll be finishing up the remaining things that we have. So, we've talked about polyps, and I'm sure none of you will fail a question on polyps. I really don't want any of you to fail a question in ENT. ENT are easy marks, grab them. ENT is like taking ice cream and cake. So enjoy it, please. Right, so you may see a question on mandibular swelling in the AKT, and mandibular swelling is not a big deal. We've talked about mumps. I've told you how it can present, but sometimes the swelling can be from inside. If you do see a patient that is having pain from the mouth when they are eating, and especially when they want to eat at mealtime, that's when the pain comes. It doesn't come due to opening the mouth. It just comes because there's food there. Please start to think that that problem is from the salivary gland. What's that? It's what we call silolithiasis. So there's some stones, and the salivary gland stones are causing the pain that this patient is experiencing. So if you see pain and swelling at mealtime, there's an obstruction. Pain, swelling at mealtime, the answer is silolithiasis in the AKT. Now, what's the difference between silolithiasis and sialadenitis? I'll tell you. Usually, there is no fever in silolithiasis. When it comes to sialadenitis, there is fever. So, fever with swelling of the salivary glands, and that swelling, what happens is there's swelling which prevents the free flow of the fluid that has been produced. So, bacteria sets in. And when bacteria sets in, that's what causes the fever in sialadenitis. And so this is different from silolithiasis, where there is no stasis and so there is no fever. Now, there is sialadenosis, which is different from sialadenitis. In sialadenosis, what happens is that there is a mass, a swelling like you're seeing in the picture, but this is a non-neoplastic, so non-malignant, so it's not a cancer. So that's what you see. So there's a swelling of the salivary gland, which can be the submandibular gland, but is not a cancer. That would be the difference. So the swelling there is not a cancer. But how will you see the question for sialadenosis in your exam? I'll tell you. It's basically a pregnant woman that presents to your exam with mouth swelling that happened just pretty recently. It is sialadenosis. Is a patient with diabetes or alcohol that has got a mouth swelling. It could also be a patient that has bulimia nervosa. So people that have certain deficiencies like thiamine and some other mineral and vitamin deficiency can have sialadenosis. So that's sialadenosis for you. It's different from sialadenitis and it's different from silolithiasis. So please don't fail it in the exam. You've got the distinguishing factors. Look at your clinchers, pick the correct option, move on. Now, in the AKT, you can see scoring systems. And I'm not going to bore you with a lot of scoring systems, but the two things I'm going to bore you with is the classification of audiogram, which I'll do later in the afternoon. And I'll talk about the scoring systems for people that have got sore throat. So you've got this patient that has got sore throat and you don't know whether to start antibiotics or not. Please, fever pain score. Fever pain score is high yield and the acronym there is FPAIN. FPAIN is F for fever in the last 24 hours, P for pus on the tonsils, A for attended within 3 days, I for inflamed tonsils, and M for no cough or coryza. So if you've seen a patient who has fever within 24 hours, you score them 1. The patient also has pus on the tonsils when you examine his mouth, you score them 1. The patient also attended on the second day, so attended within 3 days, you score him 1. The patient had an inflamed tonsils, you score him 1. The patient did not have cough, you score him 1. That's a 5/5. 4 to 5 is antibiotics. 3 is delayed antibiotics. Let me say that again. 4 to 5, you hand the patient over antibiotics, say start to use this antibiotic now. But 3 is if you get worse, if you become more unwell, use the antibiotics. So that's the difference between delayed antibiotic and handing a patient antibiotic. Anything less than 3 does not need antibiotic, is viral. Tell the patient you do not need treatment. Watch and wait approach. Now they may decide to bring the Centor scoring system instead of the fever pain score. So what do you do when they bring the Centor scoring system? I'll tell you, you need to also do the same calculation. Using the Centor scoring system, the acronym is CENTA. How do you feel that? CENTA, CENTA. The C is cervical and anterior lymphadenopathy, if present, score 1. The E is exudate, present on tonsils, if present, score 1. The N is no cough again. So if there's no cough here too, you score 1. The T there is temperature. Is the temperature greater than 38 degrees? So the temperature and fever pain score is also greater than 38 degrees. Score them 1. And the age, between 4 to 14, please score them 1. However, if it's an older patient, they score 0. In fact, if the patient is elderly, they may score -1. But the age that we're concerned about to score 1 is a younger patient. So a patient just about less than 14 will score 1. Calculate everything. If it's 3 to 4, please hand them antibiotics. If it's less than 3, like for example, if it's 2, you can do delayed, and less than 2, no treatment. So that's your scoring system. So that's your fever pain score and Centor scoring. Please go back and look at it. The more you look at it, the better you become. Use your acronym CENTA and fever pain. You can't go wrong. You can't fail it. Right. Hearing test. So we'll do more of this in our session 2. Whenever we're doing session 2, I'm going to ask you a few questions, and I would expect that all of you will be able to answer it. For example, one of the questions I can give one of you, I can just call one of you and say, well, can you tell me if a patient's Weber test does not lateralize at all, and the patient's Rhines test is positive bilaterally? What do you think? I'll be expecting a rapid answer. I call another person, I say, if the patient has a Weber test that lateralizes to the right, and Rhines test is positive bilaterally, what are you thinking about? I'll be expecting a quick answer. But today, let me just do a quick explanation of how these systems work. So the Rhines test and the Weber's test, they work hand in hand. So basically, if you see Rhines test, what we are looking for is air conduction greater than bone conduction. So A greater than B, normal. Now, you've got B greater than A. What's that? That is what we call Rhines negative. It is a conductive hearing loss. So let me start again. Rhines test. A greater than B is positive Rhines test. That can mean a sensorineural hearing loss, or it can be normal. But anytime you see B greater than A, that's bone conduction greater than air conduction, that's a negative Rhines test. It is always a conductive hearing loss. Now keep that, and now let's move to Weber's. Weber's is putting the tuning. By the way, your tuning fork is 512. If you pick 250, they ask simple questions in the AKT. The thing that pains candidate the most and can pain you for up to a month is failing a simple question. Imagine they ask that the patient has this ear problem. The doctor has brought out a tuning fork, is confused, doesn't know which tuning fork to use. Which tuning fork will be the best for a Weber's test? They put 126, they put 256, they put 512, you choose 256. 256 is for neurological examination, my friends. You can't fail this kind of questions. You will be pained. 512 is going to be the tuning fork you will use in your exam. So you get the 512 tuning fork, you've placed it on the middle of the head of the patient. He's supposed to hear the sound equally on both sides. Why? It's a bone conduction, so it's supposed to be both sides equal hearing. Now, what happens when the patient has deafness? It can be conductive, it can be sensorineural. If the sound lateralizes to an unaffected side, for example, you put the Weber's tuning fork in the center of the head and the sound lateralizes to the right side. If that right side is the unaffected side, then that is a unilateral sensorineural loss. So the side that is unaffected is usually the sensorineural. The side that is affected is the conductive. So what am I saying? Summary: Weber's will lateralize to the affected ear when it's conductive hearing loss. Especially if it's unilateral, it will go to that side. The side that it doesn't go to will be sensorineural. So if the sound lateralizes to unaffected side, just look at it. I don't know if everybody's getting me, but if you put a tuning fork at the center of the head and you strike it, you put it at the center of the head and it lateralizes, the side is lateralizing to is usually the affected side, and that's conductive. It means your other side has a sensorineural hearing loss, or is your normal side. So now, in interpretation of this Rhines and Weber's test, they may give you a question. Let's use a question. It may be very helpful to have a question. So they give you a question. They say the patient has Weber's test that lateralizes to the right, and Rhines test is negative on the right side. So what do you think? If you think about it, if Weber's lateralizes to the right, that means the right has got likely a conductive hearing loss there. But the Rhines test will now confirm it for us. There is a negative on the right side. There is a negative Rhines test on the right side. And we said that negative Rhines test is conductive hearing loss. So that is confirmed. This patient has a right conductive deafness. Well, this is what we do in our session 2. We play around with it. We look at all the whole things. We talk about it. People that are confused, we try to help them again until they get it. So please attend the session 2s. We'll do a lot of scenarios about Rhines and Weber's, and we'll play around with it. So, but that's the table you need to know for now. Please keep keep this table at your fingertips, and when we need it, we'll play around with it. So that's hearing test for you. Nystagmus, basically, there are different types of nystagmus. For the AKT, please no vertical nystagmus, no horizontal nystagmus, no rotatory nystagmus. So if you see a patient with vertical nystagmus, what are we talking about? It's usually a CNS problem. Why? The nystagmus is up and down movement. So the eye is moving up, down, up, down, up, down. And when it's moving up, it's pointing to the brain. This is your clincher. Vertical nystagmus, up, down, it means it's pointing to the brain. It's a CNS problem. Usually in the AKT, if you see nystagmus like that, even in real life, think stroke, vertebral-basilar artery ischemia or vertebral-basilar stroke. So moving up and down, vertical nystagmus is a stroke. Vertical nystagmus is a stroke. It can be other things, but this is the commonest thing you will see in your AKT. You see horizontal nystagmus is side to side. It's usually an ear thing. What is side to side is the ear, left and right ears. So it's moving from left, right, it's on a horizontal plane. That is what we call horizontal nystagmus. What type of conditions are we talking about? My friends, think labyrinthitis, especially if you have nystagmus with hearing loss. Horizontal nystagmus, hearing loss, it is labyrinthitis. Horizontal nystagmus, no hearing loss, is vestibular neuronitis. You can't fail these things in the exam, my friends. How about if the patient has what we call a rotatory nystagmus? What you will see is that the eyeball will just be moving in a circular movement. Think BPPV. BPPV is high yield in your exam. Anyways, we're coming to it, so let me not jump the gun. But you need to know everything about BPPV in this exam. It's super high yield. So those are the types of nystagmus we want you to know. There are a few more. The common ones are vertical, horizontal, and rotatory nystagmus. Mouth ulcers, please Aphthous mouth ulcers is something that you need to know everything about. And so let me start with aphthous mouth ulcers before saying anything about any other mouth ulcer. Please, the risk factors for aphthous mouth ulcer is a smoker. A smoker that stops smoking, they will develop aphthous mouth ulcers, and that's one of the things that makes them go back into smoking. So smoking is risk factor. If the patient is less than 30 and they stop smoking, they are likely to have troublesome aphthous mouth ulcer. In the AKT, there may be a positive family history of mouth ulcers. Again, if it's not a smoker, it may be a lady with COCP. So a lady on COCP, she can have mouth ulcers. Think wide in the AKT, my friends. Don't be myopic. Don't be pushed into a corner in the AKT. Be the leader of the AKT. Be the boss. Don't let the AKT be your boss. How are you the boss of the AKT? It's very simple, my friends. You need to know what makes the question easily open to you. For example, you see a patient, the patient is on combined oral contraceptive, the patient is pregnant, she's not having mouth sores. It is because of hormones. That's what I'm trying to say. How about that patient that has local trauma, broken teeth, dentures, biting, all those things, they can lead to mouth ulcers. So if you have not been listening to me, mouth ulcers, think family history. Mouth ulcers, think hormonal cause. Mouth ulcers, think trauma. Mouth ulcers, think stress. That woman that has been working 12 hours a day, she is basically stressed. She goes back home, she's back on her computer. Stress is a cause of mouth ulcers, especially aphthous mouth ulcers. How about that patient that has anxiety? My friends, there's a topic called globus hystericus. GERD symptoms with anxiety, think globus hystericus. Anxiety is a cause of mouth ulcers. Propranolol is not on the guideline for treatment of anxiety. The answer there is SSRIs. Propranolol is an off-label treatment, so you can use it, but don't go and choose it in the exam as first line. You will fail the question. That patient that likes to drink coffee and now they're having mouth ulcers, the cause is the coffee. How about the patient that takes gluten diet or a lot of peanuts? They will have mouth ulcers, and the cause will be those food. So what have I said so far? Mouth ulcers can be caused by certain food. Think coffee, think gluten product, think peanut. Mouth ulcers can be caused by stress and anxiety, as well as depression. Mouth ulcers can be caused by trauma, hormones, or family history. Now, how do we treat mouth ulcers? Basically, they are meant to go away on their own. In fact, most times your treatment does not alter the course. That's the length of the of the mouth ulcers. But many times the kind of treatment we give is supportive, maybe because of pain or for any other reason. We can give Difflam. So if you want to give over-the-counter analgesics, think Difflam. Difflam, by the way, is benzidamine. It can be mouthwash, it can be your gel, whatever it is, Difflam helps. Another one is Bonjela. Bonjela helps with relief, but it doesn't alter the length of time when the problem will go away. So that's a bit about aphthous mouth ulcers. But I want to beg one of you here who is about to make that mistake. A candidate or a patient has come to you. They've been having aphthous mouth ulcers for 4 weeks. The person is a smoker. My friend, that's no longer aphthous mouth ulcers. That is a cancer. 2-week wait. Anything greater than 3 weeks, I've said it here and I'm saying it again. This will be the third time I'm saying it, or maybe the fourth time. 3 weeks and above is the number for ENT. 3 weeks and above, something not resolving, is a 2-week wait. Nobody will ever come and tell you, Dr. A, why you always sending patient for 2-week wait? If they meet the criteria, send them. It's safer. Don't say, well, it's less likely. Meanwhile, there's a guideline which says this patient should not have mouth ulcers after 3 weeks. It's not aphthous. It's something sinister. A mouth ulcer that hasn't gone for 6 weeks, what are you waiting for? Do you want to wait for 10 weeks before you refer? It's a 2-week wait, my friends. So please, mouth ulcers are super high yield. There are a few other things I need to say about mouth ulcers, but there's no time, and our time is far going, and we still have a lot of slides. So I would leave that up. But remember, red whitish plaque in the mouth is a 2-week wait. Leukoplakia, 2-week wait. Even if it comes with So lichen planus can be a deceiving factor. It doesn't mean it's not a 2-week wait. Once you see that red, white, refer. Time length, refer. Okay, let's leave it. We'll come back to it during our session 2, where we'll do the drills. Meniere's disease, my friends. I don't know what to say again, but Meniere's disease is high yield. We have not talked about hearing loss. I don't know. Okay, I think we've talked about it. Meniere's disease is that patient in the AKT that is having feeling of fullness in the ears. I've said this thing 3 times. That is the clincher. Recurrent vertigo with feeling of fullness in the ear equals Meniere's. It's usually unilateral for patients, and acute attack treats with prochlorperazine. Now, this is how the question comes. A patient has been described to have feeling of fullness in the ear. The patient is 41. The patient is having recurrent vertigo. The patient is very unhappy. The patient has talked to you. You've examined. You are happy that this is Meniere's disease. They now say, what treatment will you give? A, beta histine. B, buccal prochlorperazine. C, oral prochlorperazine. D, IM cyclizine. Please, please, and please. Prochlorperazine is for acute attack. Beta histine is for prevention, prophylaxis. Can I say that again? Prochlorperazine, acute attack. Beta histine, prophylaxis. That's to prevent. Now, what's the difference between oral prochlorperazine and buccal? First of all, it's usually used for 7 days TDS. If you don't have that at your fingertips, please have the dosage of common medication and the length of time to use common medication at your fingertips. It's not everything that you need to check the BNF for. But now it's prochlorperazine. There's buccal on the list and there's oral. Oral is for less severe cases. Buccal will be your answer in a patient who is distressed. Please, the answer will be buccal prochlorperazine in your AKT. Assuming if you have been sleeping in the last 2 minutes, you've not heard me talk about Meniere's disease, the answer in the AKT is buccal prochlorperazine. Take that away from today. So that's Meniere's disease. I've not got a lot of time, the luxury of time. There are a lot of things I want to say, but I just thought these are some of the things that you need to know about Meniere's disease, how to recognize it, how to treat it. Sensory neural hearing loss, unilateral. Sensory neural hearing loss, unilateral. Prognosis is not too bad. Many patients will improve over time. So that's Meniere's disease, my friends. Let's look at the next one. So in the AKT, they can bring BPPV. And do you know, BPPV is so common. I know all of you have treated someone with BPPV here. And I have so many things to say about BPPV, but because it's so common, I will restrict what I need to say about BPPV. Number 1, BPPV is mostly idiopathic. Know that. Number 2, BPPV is provoked by head movement. Know that. Number 3, the vertigo are usually brief episodes, less than 5 minutes. This is different from your vestibular neuronitis and your labyrinthitis, which occurs for hours to days. See the difference? Neuronitis and labyrinthitis, hours to days. BPPV, less than 5 minutes. It's just a short time. There is usually no hearing loss or tinnitus. BPPV with hearing loss or tinnitus, red flag. That's what I'm trying to say, if you have not grasped that very quickly. Nausea is common, but vomiting is rare. If you still don't understand what I've said, BPPV and vomiting, please refer. BPPV and vomiting, there's something else happening. Probably that diagnosis is not correct. So that's BPPV for you. And we've talked about BPPV in other I've told you that you need to know all these topics at your fingertips. So please, when you see BPPV, don't fail a question on it. In the drills, all the other things I need to say about BPPV, I'll say it, but I've said the most important ones now.